Very good morning. I know I'm welcome to all. Respected Dr. Vinesh sir, सम्पूर्ण डाक्टरहरू र हाम्रो वार्डको स्टाफ बहिनीहरू, साथै स्टुडेन्ट छात्राहरू, यो हाम्रो PKMCH नर्सिङ कलेजको BNS नर्सिङ प्रोग्राम अन्तर्गत लिडरशिप एन्ड म्यानेजमेन्ट प्राक्टिकम 4 हप्ताको पोस्टिङको लागि स्टुडेन्टहरू यो वार्डमा आएका छन् र यसै क्रममा चाहिँ हरेक स्टुडेन्टले इन्चार्जसिपको रोल प्ले गर्नुपर्ने हुन्छ र इन्चार्जसिपको क्रममा चाहिँ हाम्रो स्टुडेन्टहरूले चाहिँ इन सर्भिस एजुकेसन एउटा कन्डक्ट गर्नुपर्ने हुन्छ र त्यही क्रममा चाहिँ अहिले हाम्रो यो दुईजना स्टुडेन्टहरूले चाहिँ यो BNS को दुईजना स्टुडेन्टहरूले चाहिँ चेस्ट ब्रेन ट्युब केयरमा चाहिँ नर्सिङ इन सर्भिस एजुकेसन दिन गइरहेका छन्। यो कार्यक्रमलाई चाहिँ सफल पारिदिनको लागि र यस कार्यक्रम आयोजना गरिदिनु हुने हाम्रो डाक्टर विनय सरलाई विशेष धन्यवाद दिन चाहन्छु। डाक्टर विनय सर एकदमै कुशल सर्जन जो सधैँभरि नर्सेसहरू लगायत सम्पूर्ण टिमको नै नलेज अपग्रेड गर्ने सँगसँगै नलेज स्किल र प्र्याक्टिस अनि क्वालिटी केयर यसमा चाहिँ फर्स्ट फोकस गर्ने हाम्रो डाक्टर विनय सरलाई एक कुशल सर्जन भनेर म चिनाउन चाहन्छु। मेरो यो हस्पिटलको 25 वर्षको अनुभवमा पनि मैले डाक्टर विनयलाई एकदमै कुशल सर्जन भनेर चिनेको छु। उहाँले जुन एउटा यो प्लेटफर्म दिनुभएको छ विद्यार्थीहरूलाई यो प्रेजेन्टेसन गर्नको लागि यसको विशेष धन्यवाद सम्पूर्ण टिमलाई नै दिन चाहन्छु र स्टुडेन्टहरूलाई चाहिँ प्रेजेन्टेसन सुरु गर्नको लागि अनुरोध। थ्यांक यू।
Good morning, everyone. Today we are discussing about the chest tube drain care. The contents chest tube drain care. Contents are introduction, indication, contraindications, types of chest tube drainage, chest tube sizes, chest tube insertion site, nursing care and complications. Firstly, introduction. Major thoracic surgeries exert tremendous physiologic stress on patients. To obtain the best results, peri-operative care must be optimal. Chest tube care is one of the most important aspects of ensuring the recovery for the patient. Chest tube drainage is the insertion of flexible tube into the pleural space to evacuate air or fluid to help regain negative pressure and thus promote lung expansion, which is accomplished by an use of an underwater seal. Indications: pneumothorax, air in the pleural cavity; hemothorax, the presence of blood in the pleural space; pleural effusion, accumulation of the fluid in the pleural space; chylothorax, a collection of chyle, a type of the lipid-rich lymph in the pleural space; empyema, a pyogenic infection, pus of the pleural space; hydrothorax, accumulation of the serous fluid in the pleural space; post-cardiac surgery or thoracic surgery. Next, contraindications: bleeding disorders or coagulopathy, then pulmonary, pleural or thoracic adhesions, skin infection at the insertion site. Then we discuss about the types of the drainage system. There are 3 types of chest drainage systems. First, 1 bottle system, 2 bottle system, and 3 bottle system. Let's discuss by the picture. In the first picture, there is the 1 bottle system where the in this 1 bottle, the drainage from the patient side is collected in this bottle, and there is also a water seal drainage system where the air collected from the patient are collected and escape from this to the environment. In water seal chamber, the water level should be 2 centimeter and that tube should be dipped in the water. In the second picture, there is 2 bottle drainage system where there is the first bottle is used for the collection of the drainage from the patient, and next bottle acts as a water seal drainage which prevent the air backflow to the patient side. In the third bottle drainage system, there is 3 bottles. First is for the collection of the drainage, second is used for the water seal, and third for the suction control. In our ward, there is commonly used suction drainage system is this type of suction three bottles drainage system is used. This is the in three bottle system there is the three chambers. First is the for the collection chamber, second for the water seal chamber, and third for the suction. Post drain are collected in this collection chamber, and this water seal chamber acts as a water seal for which prevents the backflow of air to the patient, and water should be 2 centimeter level. In the suction control chamber, the suction pressure should be maintained minus 20 centimeter of water. In this suction chamber, the continuous bubbling present at this chamber, and in water seal chamber, the tidalling, which is also called the movement of the water, should be maintained. If the continuous bubbling occurs in this chamber, immediate actions to be taken by the nurses. Watch for the sign of air leaks. Air leaks or kinks should be monitored. The compartments are discussed previously: the collection chamber, water seal chamber, and the suction control chamber. Uh, in suction control chamber, there are two types of suction system: wet system and dry system. In wet system, there is the use of water, and in dry system, there is no water. Water is not used. Only suction is regulated by the outside monitor, which is maintained at the minus 20 centimeter of water. Uh, Test tube sizes. Test tube sizes vary depending on the proposed patient's age, size, and clinical condition. In the neonate, 10 to 12 frames of the test tube sizes are used. In infant, 12 to 16 frames are used. In child, 12 to 18 frames test tubes are used. In adult female, 28 frames chest tube size is used. In adult male, 28 to 32 frames of chest tube sizes are used. In our ward, commonly 24 frames of chest tube sizes are used. Chest tube insertion site. Safe triangle. The safe triangle is a well-defined anatomical region that minimizes complication during tube insertion. The triangle is bordered anteriorly by the lateral border of the pectoralis major, posteriorly by the anterior border of the latissimus dorsi, and inferiorly by a horizontal line of the nipple level, fifth intercostal space, with its apex just below the axilla. In this picture, the edge of anteriorly the edge of the pectoralis major muscle, posteriorly the edge of the latissimus dorsi muscle, and inferiorly horizontal line from the nipple, that is at fifth intercostal space, and base at the apex base of the axilla. This site is known for the safe triangle for the chest tube insertion. In pneumothorax, the tube should be directed upward toward the apex, second or third interspace along mid-clavicular or anterior axillary line. In hemothorax or pleural effusion, a posterior oriented placement, sixth or seventh lateral interspace in the mid-axillary line are inserted. Remaining portion of the presentation is continued by my friend. Thank you all.
Once again, a warm good morning to all of you. And moving on to the next content, a care of patient having chest tube drainage. First, the initial and ongoing assessment for chest tube drainage. It is important and fundamental for safe chest tube management, focusing on the only complication and treatment efficacy. Similarly, in the first 2 hours, immediate post-insertion assessments will be done, in which the vital signs are monitored, especially blood pressure, heart rate, respiratory rate, and oxygen saturation every 15 minutes for first 2 hours to notice the sign for the hypotension or respiratory distress. Similarly, in respiratory status, auscultate the bilateral breath sounds hourly, note diminished sounds or new wheezing. Insertion site, inspect for bleeding, dressing integrity, and subcutaneous emphysema, in which the crackling under the skin are heard. In dressing integrity, we should observe for whether the dressing is intact or not, clean or not, dry or not, or soap is present or not. Similarly, in pain assessment, we can use the pain score scale, 0 to 10 scale, in which the more than 4, if the patient indicate more than 4 score, then we should start the analgesics. Similarly, obtain the chest X-ray within 2 hours of insertion of chest tube or as protocol. In our hospital, BPKMCS, the chest tube are mostly inserted intraoperatively, so we do the chest X-ray mostly after the 24 hours. Similarly, after the beyond 2 hours, ongoing monitoring and management, vital signs, monitor respiratory rate, heart rate, blood pressure, SpO2 level, check every 4 hours or unless the patient is stable. Similarly, in drainage system, we should monitor for volume or character, document the color, serous, sanguineous or purulent discharge and amount hourly initially, then every 8 hours. In drainage type, in the types of drainage, we can see serous drainage, serosanguineous fluid, and the purulent drainage. In serous drainage, it is of a clear or pale yellow color, which indicates the is mostly seen in the non-inflammatory pleural effusion cases. Similarly, in serosanguineous fluid, it is the most combination of the serous and sanguineous, in which the serous clear or little blood is mixed, but it indicates the no excessive hemorrhage. It is mostly seen in the little vascular injury. Similarly, in purulent drainage, it is mostly seen in the empyema case, in which the thick and yellowish discharge are present. And this is the chart of drainage which is placed in the nursing station: serous, serosanguineous, sanguineous, chylous, and the post drainage. Similarly, in the drainage system, water cell chamber, we should observe for the conform gentle tidling, fluctuating breathing, and absence of the continuous bubbling. If the continuous bubbling is present, then it may indicate the air leak. Similarly, in the suction control chamber, we should observe for the initial prescribed suction level is maintained, which is minus 20 centimeter of H2O. Similarly, in the respiratory function, we can assess for the dyspnea, tachypnea, or asymmetric chest expansion. Encourage coughing or deep breathing every 2 hours. In ward, we encourage for spirometry, which is done. And in tubing, we check for kinks, dependent loops or clots, ensure the tapes are secured. Similarly, in the vascular complication, we can observe for the tension pneumothorax, in which the sinus symptoms may show sudden hypertension, tracheal deviation, or absent breath sound. Similarly, in the infection, fever, purulent drainage, or arrhythmia at the site, reaction, pulmonary edema, hypoxemia, or clacus or rapid fluid drainage may be seen. Reaction and pulmonary edema is the complication in which the lungs are rapidly reinflated. This is a picture of tension pneumothorax, in which the trachea is shifted because of the tension pneumothorax. Drainage system management, it is critical for maintaining the chest tube function, preventing complication, and ensuring the patient's safety. System setup and positioning, in which the patient is upright position, keep the drainage unit vertically aligned and below the chest level to facilitate the gravity-driven drainage and prevent the black flow. Similarly, in tubing alignment, ensure the tubing is free of kinks, dependent loops, or compression under the patient or bed rest to maintain the patency. Chamber specific management, collection chamber, document the drainage volume, color, serous, sanguineous, or purulent, and consistency hourly initial, then every 8 hours. Notify the medical staff immediately for sudden changes, example, more than 100 ml per hour or bright red in drainage. Similarly, the test stream chamber needs to be emptied when it's 3/4 full or if accident disconnection present. In the water seal chamber, maintain the sterile water at 2 centimeter level to ensure the one-way valve function. Monitor for tidling, fluctuation with respiration, indicating system patency, continuous bubbling signals, and air leak. Suction control chamber, verify the prescribed suction level, minus 20 centimeter H2O, and ensure the gentle bubbling system in wet system or dye setting in dry systems. Avoid the overfilling, withdraw the excess water if needed. In the drainage system, troubleshooting common issues, in which the problem may be seen yearly, clamp tubing near the insertion site. If the bubbling stuff leak is present in the patient site, gradually move clamp toward the system to locate the leak. System disconnection, clamp the tube at patient, clean the connectors and reconnect. If the contaminated, submerge in the sterile water temporarily. Drainage cessation, check for clots or kinks, reposition the patient upright, notify the provider if unresolved. System tipping, upright immediately, refill the water if depleted or if contaminated. System tipping means if accidentally it tilted or fall. Safety and maintenance. Never strip or milk tubing. Displace the dangerous negative pressure. Gently manipulate only if the clots are visible or prescribed. Avoid clamping. Clamping breaks the tension pneumothorax unless ordered by physician. Emergency readiness. Keep the sterile occlusing dressing and sterile water or normal saline at the bedside for accidental dislodgement. Moving on, site and dressing care. Site and dressing care for chest tube drainage involves the meticulous attention to prevent the infection, maintain the tube stability, and promote the healing. It includes dressing, maintain the sterile occlusive dressing over the insertion site to prevent the air leaks and infection. Commonly used dressing are sterile 4x4 gauze or petroleum Vaseline gauze. Inspect the dressing frequently, initially every 15 minutes for first 2 hours post insertion, then at least every shift or for facility protocol. Change the dressing if it becomes wet, swelled, or loose using sterile technique. Secure the chest tube with sutures or additional tape or omental tag or tape loop securing the tube to the skin to prevent the dislodgement. All belts are secure to fix the drain. This is the omental tag picture in which it is rarely used in here in our hospital setting. In our hospital setting, belts of secure is mostly used in which the chest tube drain is fixed. Insertion site care. Keep the site clean and dry. Clean around the insertion site gently with an appropriate antiseptic solution during dressing changes. Assess the skin around the site for sign of infections such as redness, swelling, warm, tenderness, or purulent drainage. Palpate for subcutaneous emphysema, crepitations which may indicate an air leakage under the skin. Monitor for bleeding or hematoma formation at the site. Patient instruction and safety. Instruct the patient to report any chest pain, difficulty in breathing, pain, or increased drainage, etc. Keep the emergency supplies at the bedside. Sterile gauze, petroleum gauze, tape, and clamps for immediate management if the tube becomes dislodged or dressing compromised. If the tube is accidentally dislodged, apply an occlusive dressing taped on the 3 sides to allow the air escape and prevent the tension pneumothorax until the provider arrives. This is the picture of occlusive dressing which is taped in the 3 sides, in which the one side is left open to escape to let the air escape and prevent air from entering. Documentation. Record the condition of the insertion site and dressing, drainage system assessment, patient assessment, noting and changes or intervention performed. Document any complication or issues encountered in the chest tube drain. Document and teaching provided to the patient regarding the chest tube care and their understanding of the information. And the indication of the chest tube removal. Drainage diminishes to little or nothing less than 100 to 200 ml per day. Absence of an air leak. Chest X-ray shows long re-expansion and the improved respiratory status of the patient. Complication of the chest tube drain. Pain, chest wall or neck and shoulder. Infection at the insertion site or intrapleural region. Penetration and laceration to the lungs. Penetration of the peritoneal space, laceration of the diaphragm, tension pneumothorax, hemorrhage, blocked drains, pleural sepsis, and the subcutaneous emphysema. And in conclusion and recommendation, different articles were reviewed and studied in which in Nepal there is limited study or no article have been published. So these 2 articles have been taken. First one is a descriptive exploratory study was conducted among 60 ICU nurses to assess the nurses' knowledge and practice in Egypt 2022, which shows only 41.7% of nurses had average level of knowledge and 35% had poor level of knowledge and only 23.3% had good knowledge of chest tube drain. Similarly, a cross-sectional study was conducted among 141 nurses in Nigerian University Hospital, which showed only 26.2% had good knowledge of nursing care of chest tube drain care. And we have conducted in-service education on 19th Osar among the staff, nursing staff in thoracic ward, in which the pre-test question was distributed. Overall, 10 question was distributed, in which sorry for the distraction. Based on the pre-test result conducted in the in-service education, 72.5% has knowledge on chest tube drain care. However, after the study session, the percentage has risen to 90%, which shows the effectiveness of the class. And the recommendation, based on the current study results, regular continuous educational program on the chest tube and its care should be organized for enhancing the nurses' knowledge and practice to achieve the high quality care. And this is the references we have taken. Thank you.
Thank you very much. Okay, sir. Today this is over. Thank you very much. So, I mean, you people opened our eyes because you are the doctors, and sometimes we think at what level the nurses understand about the chest, particularly talking about the chest tube drainage system. So we got quite surprised. We have very sound knowledge, theoretical knowledge, not only the practical. Because the practical knowledge is quite important. Everybody from our world, they are perfect. That is whatever you have said, they know very well. But in the theoretical terms, you need to express what you have been doing. So that's a very good thing that you have talked about today. So what I found that there are a few things that I would like to highlight. You have done very well there. So have you ever seen a plastic bag, like Euro bag collection for the urine, that is being used for the chest tube underwater seal? Bag, not the bottle. You have seen in our world, there's no underwater seal bag as such. We always utilize the underwater seal bottle. Have you seen ever the underwater seal bag? No. So I would say that whenever you will go to the respective departments of some other hospitals to work with. So in the beginning, what happens in the general hospital and quite often in the medical college also, they start with the underwater seal bag. So first you suggest them, your nursing chief or whoever is there, suggest them at least that this bag should be omitted, avoided, because it's not very comfortable to carry for the patient. The patient can quite easily spill the bag and the water may come out, and also they can make injury to the bag. It's such plastic, some injury, and it will be not underwater seal anymore, but the water may spill out. So therefore, the first message should be avoid using the plastic bag like urinary collection system, the underwater. So always use the underwater seal bottle. So you said very well, there is the one bottle system, two bottle system, three bottle system. So in our world, you might have seen the single bottle system or double bottle system, sorry, and the triple bottle system. So we generally do not use the single bottle system because there will be the collection chamber and the underwater seal at the same price. So the cost effectiveness is there. So only using the single bottle system also should be omitted. The practice should be like that. So double bottle system is good if you don't need the suction, and triple bottle system is very well. So the first question to you goes like that: when do you say that there is a recommendation for the double bottle system and the triple bottle system? Does each and every patient requires the triple bottle system, which costs about 7,000 or 7,000 roughly in every currency, whether the single or double bottle system without the suction costs about 1,500 or 2,000. So the cost is of importance in our system also. What do you think, according to you? Does each and every patient, madam? So, does every patient require or not? What is your recommendation? You have done the theoretical study. You have even made a pre-test questionnaire to our nurses, who are, I think, the most perfect nurses in our hospital regarding the thoracic services, right? So, is the idea? What do you think? Does each and every patient require the triple bottle system? I mean, the suction. The answer should be no, because whenever the patient requires the suction, then we can have the triple bottle system or generally not. The next message that you have given us that any patient who is undergoing the thoracic surgery or cardiac surgery, one of the points he has mentioned, requires the chest drainage system, right? So there is an exception when this chest tubes can be omitted or should not be used or should not be connected to the chest bottle. That is once the whole lung is removed, the pneumonectomy. So when the whole lung is removed, that you do not need to connect to the underwater seal, or you can totally omit the chest tube. This one exception that you cannot. You don't need the chest bottle. And right now, because we are moving ahead, there are certain surgeries, thoracic surgery or cardiac surgeries, when you're quite sure during surgery, there is no air leakage during surgery, and there is no necessity in putting the chest in. Right? Air leakage had kinara. Intraoperative to confirm lung surgery or whatever. There's no necessity of putting. So there are certain exceptions that you can do. Most important molecule when you mentioned quite a lot of how the dressing should be done, how the care after the drainage system should be done. I'm quite sure that in our ward also the nurses are doing the same thing. Okay, it's not the just according to the theoretical points. We understand those theoretical parts, and you have to do. The one thing I think that should be missing in our is documentation. Documentation takes quite a long time. You can omit some of the points, but I insist that some of the points that she has raised there, documentation should be proper. So documents like what amount, when amount, which amount, what's the satisfaction of patient, what's the pain scale, etc. When to use the analgesic or not. So that categorization has to be done not only from the physician's part, but also should be done from the nurse's part. So she has mentioned one very important point in their lecture. And then she mentioned very well that it opened my eyes. We have been doing since last 27 years of thoracic surgery in our hospital. I think none of, she said there is no literature regarding, article regarding the chest tube drainage so far in Nepal, right? We have been publishing the thoracic articles every year, twice a year. I missed that our nurses should be doing this quite also. कति छ कसैले लिनु आजैदेखि make it habit. Just she said knowledge के भने this was the qualitative study होइन. Nigeria is a poor country, Egypt will be a vast country, but the habit performing this kind of thing can be done in our world. What do you think? What just only this observational descriptive study or cross-sectional study in 2 months of period, you can have 50 patients. 50 patients त हुन्छ 2 महिना. Just look what size of the chest tube drainage do we use in BB caves. It's simple. She said 24 frames, 20 years, somebody will add 24. Mostly we are using 24. So you can say that 24 frames should be a standard practice in low income resources country like us. You can provide the regions. 24 मात्र use गर्छ. We do not think anything else in low resource country like Nepal. यो त conclusion बनाउन सक्यो नि. Second, जस्तो उहाँले भने knowledge practice जुन नयाँ हाम्रो nurses छ when they come here or after 3 months हुन सक्छ म्याडम 25 years काम गर्नुभएको छ हाम्रोबाट उहाँ काम गर्छ कतिकै 1.5 वर्ष कतिको तपाईहरु कति वर्षको काम गरेको according to the degree के भन्छ years of experience with the thoracic services, what is their knowledge, like they categorize into high knowledge, satisfactory knowledge and poor knowledge about the chest drainage system, then how much our nurses to know about this, though they are working with the thoracic services. त्यो पनि एउटा स्टडी तपाईले गर्न सिमिलर टु द आर्टिकल पब्लिश एन्ड क्वाइट सर्वे नेपालमा कसैले गरेकै छैन कुनै नर्स सो सिम्पल. सो तपाईहरु म एक्सपेक्ट गर्छु नाउ यो हाम्रो एनुअल डेमा वी आर गोइङ टु द पब्लिश द जर्नल. आई एक्सपेक्ट एटलिस्ट 2 आर्टिकल्स फ्रम आवर डिपार्टमेन्ट. तपाईहरु लेख्नु वी विल हेल्प यु. तपाईहरु लेख्नु 2टा आर्टिकल हाम्रो वार्डबाट आउनुपर्छ. एउटा गुड आई ओपनर यो मलाई थाहा थिएन कि हाम्रो नर्सहरुले यस्तो रिसर्च गरिराखेन. गर्नुस् तपाईहरु पनि भेरी वेल डन. म तपाईहरुको कन्ग्रेचुलेट गर्न चाहन्छु. Thank you. Any comments from you, the mentors from the nursing department?
अब हामीले डकुमेन्टेसनहरुको त फिडब्याक पनि आयो कति बेला ट्राभलिङको गर्ने आयो हामीले त्यसलाई चाहिँ थोरै वार्डमा चाहिँ चेकलिस्ट बनाएर डकुमेन्टेसनलाई अझै इम्प्रुभ गर्नको लागि चाहिँ चेकलिस्ट बनाउने यो चेस्ट प्रिभेन्टिभ केयरमा पेसेन्टको कम्प्लेन्ट्स प्रोब्लम्सहरु के हामी त्यहाँ अलरेडी डकुमेन्टेड भएपछि
तपाईहरुले कति दिन बाँकी छ? कति बाँकी छ? 3 years. Now before leaving this department, unit, बेला बाँकी जाने गर्न हामी पनि आउँदैछौँ भने अब समर्थन चाहिँ भन्दैन. So before leaving this unit, हैन, please print out the chart. A lot of work has been done and published in this oncology book. You mentioned the reference by our Janaki ma'am. She has written a very good chapter about the pleurodesis and pleurodesis. So similar. So you just print out in 3 charts. Or 1 chart is okay. How to care about what things that we have to look from the nursing perspective, and just simple knowledge about the test from the patient's point of view. ठीक छ? They will print out 3 charts. And I will provide please them the QR code of our unit. So they will print with the QR code. So that every patient can scan their QR code for the patient and they can read it home. Right? So what is the chest tube for patients? परिभाषामा लेख्नुस् एउटा चार्ट, एउटा नर्सिङको परिभाषामा लेख्नुस्, एउटा डाक्टरको परिभाषामा चाहिन्छ. यो दुईटा हामी चाहन्छौँ तपाईले चाहिँ जाँदै गर्दाखेरि दुईटा चार्ट प्रिन्ट गरेर त्यहाँ लेख्नुस्. ठीक छ? सफ्ट कपी पनि हार्ड कपी. तपाईँले भन्दै हुन्छ सर यहाँ
चेन्ज प्रोसेसमा यिनीहरूले यो लिडरसिप एन्ड म्यानेजमेन्टकै प्र्याक्टिकलमा एउटा हिसाब बुझ्ने भयो। त्यसको सँगसँगै चेन्ज प्रोसेस पनि गर्नुपर्ने हुन्छ। अनि त्यही चेन्ज प्रोसेसमा हामीले यही टेक्निक्स अथवा भने चाहिँ टेस्ट बनाएर डकुमेन्ट वार्डमा हामी राख्छौँ। त्यो चेन्ज प्रोसेस पनि यही नै हो। सरले हामीले देखायो
अब डक्टरबाट केही छ भने तपाईँलाई कस्तो लाग्यो उहाँको त्यो विकास तपाईँको कस्तो लाग्यो होइन नर्सेस प्रेजेन्टेड what's your opinion what's your feedback because we think always from the doctor's point of view never went into how the nurses think what difficulties they are facing in the chest tube we never know what's your opinion do you want something to add on what they said
everything is fine but there are a few things like you said monitoring every 15 minutes those are the few things that are not actually possible in our setup because we are the nursing manpower, they are very less in our setting. Generally, we see in our hospital, we see 2 nurses who are involved in caring of 20 patients. So those things may not be actually possible. But what best we can do is, if you have any suspicion, if you think anything is abnormal, it's always better to inform the doctor on duty so that there's no any mishap happening there. The rest of the thing, I think. Good presentation.
सागर आज सबै सचिव के भन्नुहुन्छ तपाईँहरुलाई भाषाबारे के भन्नुहुन्छ स्टुडेन्टहरुलाई के सोध्नु छ भन्नुस् न लास्टली फ्रम द स्टुडेन्ट्स तपाईले के हाउ डु यु थिंक हाउ टु असेस देयर प्रेजेन्टेसन तपाईलाई कस्तो लाग्यो इट्स गुड एजुकेसन हामीलाई
temporary management.
Thank you.